Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasaka sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada pang tayo'y magkakasama, sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Magsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala at kwento natin ng katuwa at bighatin, sa lahat ng pangyayari na nagbubog sa atin. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Lupin medisina.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon. Good afternoon to all of you, all of those who are in the Zoom, as well as on Facebook, and those who are in the UP Manila live stream. Good afternoon. Thank you for being here. And before we proceed, let me introduce myself. I am Dr. Donna Pangilinan Simpao. I am a primary care consultant at the Centro Medicale Internazionale, and as well as right now, I am a trainee at the Philippine College of Lifestyle Medicine. So balik estudyante po. And of course, I am a member of the Silver Jubilarians of this year, the UP College of Medicine class 1998. And speaking of 98, our batch, our class is seeking or attempted to give 98 offerings through 96 webinars, as well as 2 post-grad. And today, as we celebrate Advanced Heroes Day, Bonifacio Day, I just like to honor everybody, pati po yung mga nanonood, for supporting this endeavor. And of course, our webinar team led by Dr. Teddy Abildera, Dr. Denny Sakdalan, and Dr. Ana or Orange de Guzman. Shout out to all of you. Maraming salamat. And of course, to the UP Manila webinar team. And to everybody out there, frontliners, maraming salamat for joining us today on our 94th webinar. Diba? Okay, so speaking of today's event, it's very, very special as we, today is November 27. It is exactly 28 days to Christmas. And for those who have faith or the Christian faith, it is a season of preparation, anticipation. It is a season of preparing for a birth, for a delivery, and for a newborn. So today is an extra special webinar because we have a tandem. We invited 2 of our batchmates, 2 experts on OBGYN and on pediatrician to discuss our wonderful topic. It is my honor to introduce my classmates from the UP College of Medicine class of 1998. To start our session, we have Dr. Rosibel Candido Esguerra, or Rose, to our batch, is a clinical associate professor at the section of reproductive medicine at the Department of OBGYN at the PGH. And then to follow is another batchmate, Dr. Resty Bautista, is an associate professor of the UP College of Medicine, and as well as the chief of division of newborn medicine, also at the UP PGH. So today they will talk about the so-called 4th trimester of life, or life with a newborn. So hello, Dr. Rose and Dr. Resty are here. Hi there.
Good afternoon.
Yes, and now I would like to call on Dr. Rose Esguerra to start our session.
Thank you. Do you see it clearly?
Yes. However, we see it as a slide presentation, as a presenter's view.
Okay, let me go back. Wait. Just a minute.
As we try to figure out, I would just like to thank those who are here. I know it's a holiday and some are probably out of the country or out of town. Ayan. So I think it's in presenter slide.
Wait.
So we can see your
Sorry.
side. Yeah, no problem, no problem.
Actually, it's in the center, but I can.
As we wait, we invite our viewers to join our next webinar on COVID-19 in children. And our expert speaker will be Dr. Anna Ong, Professor in Chief of Division of Infectious Disease. So are we ready? I think you can put it on slide presentation. Or like full screen, perhaps. Maybe ask our tech team to just maybe give some advice.
Just a minute. Okay.
Yeah, I think you can put it on view and then full screen, perhaps.
Wait. Sorry, it's taking some time. Stop it. Wait.
Or it's possible also that you can reshare screen and open it only showing
There.
your slide. Yeah, reshare screen and okay.
Wait. There. Okay, and then I'll go there and advanced files, share. Sorry.
Dr. Rose, can we stop share muna? Stop share
Okay.
screen and then you open your field, because there's a way where you will just sort of highlight the box of the slides.
Wait. Okay.
There. What did
Can
you
you
do?
see
That
it?
worked. There you go. Yes, just a slide. We apologize for the little delay, but I think we are ready.
Okay.
Okay.
Can you hear me? Can everyone hear me?
Okay, sorry, something happened again that the other slides are showing and your notes are showing. Okay,
Wait.
so
Wait.
So here you just change here. This
I
is
can't.
we see the entire slide. If you press next, let's try. Can you try to put? Oh, it's really like that. Okay, so okay, again, sorry. Can you stop share screen, Muna? Would you like us to hang on. Yes. Yeah. There is a way in which when you share screen, it will ask you to highlight just the portion of which you plan to share there. Okay. Yes, I can see. And then can you try to press next slide just to see if this... There, now you got it. Okay, sorry for that delay.
Oh, so sorry.
Okay, so let's... Okay, so again,
So,
Dr. Sibel Esguerra will present to us the 4th trimester.
Okay. A pleasant noon to everyone. I was tasked to give a 10-minute mini lecture on the 4th trimester, otherwise known to us OBGYNs as the porphyrium. I will be discussing the maternal aspect of the postnatal care. So for most women, childcare and the postpartum period are exciting and special life experiences. The fourth trimester is a period of physical, mental, and social change. Although many women transition through this time uneventfully, some may find it overwhelming and develop significant health issues that may persist for weeks and months after giving birth. So today's lecture, I will focus primarily on postpartum care and its components. So the word puerperium is derived from Latin, puer, meaning child, and parus, meaning bridging forth. It defines the time following delivery, during which various anatomical and physiological changes in the mother return to the non-pregnant state. As importantly, this is also a period of mental and social change. So there are other terminologies used to define this period. The terms postnatal period and postpartum period are used interchangeably. Often, postpartum refers to issues pertaining to the mother, while postnatal refers to those concerning the baby. However, based on the 2013 WHO consensus, they recommended the term postnatal to be used for all issues pertaining to the mother and baby after birth. It begins immediately after the birth of the baby and extends up to 42 days after birth. So it consists of three periods: the immediate, early, and late postnatal period. So the immediate postnatal period covers the first 24 hours from birth. It is during this time that the risk for the mother of postpartum hemorrhage and other significant morbidity are highest. So close supervision by a skilled attendant is required so that any problems that can be identified promptly can be given appropriate intervention, or referral can take place immediately. So the early postpartum period refers to days 2 to 7, and it is during this period that problems with infant feeding or infection may manifest. And days 8 through 42 are referred to as the late postnatal period. So I will be centering my discussion on the early and the late postnatal periods. So, although the postnatal period is much less complex compared with pregnancy, maternal complication, morbidity, and even mortality is surprisingly common. Studies have shown 70% of women describe at least one physical problem during the first 12 months after giving birth. For 25% of these women, the problem is deemed to be of moderate severity, while 20% may have more severe problems. So according to the annual report of the PhilHealth Services Information System of the DOH, in 2022 alone, there were 914 maternal deaths recorded. Maternal mortality ratio is at 64.68 per 100,000 live births. So most deaths occur during or immediately after birth. So majority of these complications were preventable. Therefore, the need for a comprehensive postpartum care to prevent and manage complications and to ensure health of the mother and the child cannot be overemphasized. Despite its recognized importance, however, postpartum care remains inadequate and relatively low in the Philippines. So, based on the 2022 DOH statistics, postnatal care is low at 60 to 70% or even lower in some areas. So, identified barriers for women who seek postpartum services include lack of childcare, inability to get an appointment, mistrust of healthcare providers, and limited understanding of the value of the visit. So these barriers are even more challenging for low resource populations. So according to the 2013 WHO recommendations, postnatal care should be rendered within the first 24 hours, after which at least 3 additional postnatal contacts are recommended for all mothers and newborns on day 3, between days 7 to 14 after birth, and 6 weeks after birth. However, ACOG recommends an initial visit after 3 weeks and the final summary visit at 12 weeks. So there are only 2 recommended postnatal visits according to ACOG. Then transition to a well woman care or primary or specialty care when necessary. So visits, though, can be added as needed between this time. So during the postpartum visit, a full assessment of physical, social, and psychological well-being should be conducted. It should include the following components: the care team, the postpartum visits, lactation support, infant feeding program, which I think will be discussed by Dr. Resti later, contraception, pregnancy complications, cardiovascular risk assessments, mental health, postpartum problems, and chronic conditions. Unfortunately, due to the interest of time, I will not be discussing all of this. Instead, I will be sharing with you the ACOG Postpartum Toolkit. So in 2018, ACOG developed an educational tool meant to help healthcare workers implement a more comprehensive postnatal care in their practices. So it includes resources on the key components of the postpartum care, such as immunization during postpartum period, postpartum complications, reproductive life planning, contraception and sexual health, support teams for the new mother, breastfeeding, and achieving a healthy weight in the postpartum period. So this is among others. So I will be focusing my discussion on these components. So postpartum maternal immunization is recommended as it can prevent acute maternal infection and potential spread of illness from the woman to the newborn. It also allows the infants to acquire maternal antibodies through the breast milk. So the following are the CDC vaccine recommendations for postpartum women. So Tdap and influenza, chickenpox are recommended to be given if without documentation of previous vaccination. Hepatitis A, B, pneumococcal, and meningococcal and MMR are to be given only when risk factors are present and patients are susceptible to the infection. So how about HPV? The succeeding doses of HPV can be given during the postpartum period. And if the patient is less than 26 years old and never had HPV vaccination in the past, then we can start the series of vaccination during the postpartum period. Live vaccines, example, would include oral polio, BCG, are also safe for breastfeeding women. So likewise, immunization is also recommended for all household members and caregivers who are in contact with the newborn. So as mentioned earlier, women in the postpartum period should be monitored for postpartum complications. There are so many possible complications during the postpartum. So what can actually help us focus on whatever postpartum complication there would be is to get a very good clinical history, a thorough understanding of the labor and delivery process would be very helpful. For example, the hours of labor, and was episiotomy done, what degree of episiotomy was done. So these are very important aspects of the clinical history. So postpartum complications would include urinary and fecal incontinence, perineal pain, dyspareunia, and sexual dysfunction. So anticipatory counseling in the prenatal period regarding routine procedures and postpartum changes should also be included, as it empowers our patient to understand what to expect, recognize changes, and be able to advocate for their health care needs. So, reproductive life planning and contraception, as well as sexual health, are also issues for virtually all patients in the postpartum period. So the physician should ask the patient's reproductive life plan, including plans for future pregnancy, assess whether sexually active or not, and if they are sexually active, is there need for contraception, and to tailor this contraception according to medical comorbidities, future pregnancy plans, and patient preferences. It is also mandatory to screen for readiness for sex, sexually transmitted infection risk, sexual abuse, and sexual dysfunction. So the physician should also look into the mother's support team. So questions such as, how has everyone been adjusting to the new baby? So by asking this, we are actually acknowledging the new demands on the family. So this is also a good way to screen the women and their partners for difficulties and possible depression. So it may also include, does every family member have a role? So counseling of the support team should include encouraging each family members to have a role in caring for the mother and the newborn, to educate the partner on breastfeeding, to identify resources available for immunizations and depression treatment, and to discuss the effect childbirth may have on the sexual relationship of the couple. So breastfeeding should also be recommended. So obstetric care providers should support women who desire to breastfeed and should implement the 10 steps to successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes, which I will no longer be discussing here, but should there be any questions later on, I will gladly answer the questions. So the U.S. Preventive Service Task Force recommends a one-on-one counseling about breastfeeding to be conducted by the physician, the nurses, and allied professionals at different stages during pregnancy. So we should also have a support system by a lay person, like the breastfeeding coaches, which I hope Aresti will be discussing later on. And formal breastfeeding education throughout the prenatal and postpartum periods through group sessions is also very much recommended. So achieving a healthy weight in the postpartum patient should be highly encouraged. Healthy weight loss is defined as 1 to 2 pounds per week, and exercise can be instituted at 150 minutes of moderate exercises per week for uncomplicated pregnancy, or about 20 to 30 minutes of exercise on most days of the week. So when do we resume exercise? For uncomplicated vaginal delivery, patients can resume an exercise program as soon as they are comfortable. Okay. So, but in patients who are post-op, who underwent cesarean section, they can resume full physical activity in 4 to 6 weeks after cesarean section. So how about exercise? Does it interfere with milk production? Because some women may express concern over this. So studies have shown that exercise does not interfere with milk production. And diet with regards to diet, an increased caloric intake by 500 calories per day is needed for milk production. So we will have to advise our patients to eat more and exercise more. So I think this is my last slide. I placed it here because I wanted to remind everyone, especially the OBs and the primary care physicians, no, to look into the chronic diseases that have emerged during pregnancy, or as some of these may have worsened during the pregnancy and are a significant cause to morbidity and mortality during this period. So it is important to note that these chronic medical conditions can have an exacerbation, okay, in the immediate postpartum and often may need a multidisciplinary approach in terms of care. So I think that's my last slide. Thank you very much.
Thank you, Dr. Rosabel Esguerra, for that enlightening session. And now we proceed to Dr. Resty, adjusting to the life with a newborn.
Thank you, Rose. And thank you, Donna. Is my sound okay? Good afternoon, everyone. Thank you, Rose, for setting the context for our webinar. Rose actually has 3 times more experience than me taking care of a baby. She had triplets. I had only one in my life. We only have one baby boy. So she has 3 times more experience than me. All right, so we'll talk about the 4th trimester. The idea of the 4th trimester is attributed to pediatrician and author Dr. Harvey Karp from his book, The Happiest Baby on the Block, published around 20 years ago. And Karp's theory is that human mammals, unlike other mammals, are born fundamentally helpless. For example, most mammals are able to walk. So you've seen a baby horse or baby elephant. Right after being born, they can already walk. Right? But it takes most humans a good year to master that skill. The reason humans are born early is because if we stayed in utero longer, our heads would be too big to fit through the birth canal. And I find it that Karp's theory helps us understand human babies are born essentially before they are actually ready to be born, which means they require a lot more attention and care than most mammals do after birth. And if we remember the fetus, not only are babies not fully developed yet, Karp says that babies are born missing the womb, and much of their fussing and neediness in the 4th trimester, in the first 3 months, has to do with a feeling of disorientation and an inability to self-soothe without assistance. Remember your life in utero. As a fetus, you were happily swimming in a dark, contained, and safe environment with a continuous supply of everything you need: gas exchange, warmth, protection, hydration, nutrition. And newborns experience their mothers in the womb through taste and smell of amniotic fluid. Fetuses become familiar with the rhythm and whooshing sound of the mother's heartbeat and the cadence of mommy's voice and other people around, and also through movement when the mother is walking, etc. So this concept of the 4th trimester helps parents, and I think in the audience are our healthcare givers, our healthcare workers, to understand that many newborn behaviors, such as a constant need to be held, to be fed, rocked, and shushed, stem from the fact that babies are still adjusting to life outside the cozy and familiar quarters of their mother's womb. So our goals as healthcare providers, as assistants to these parents and families, are these. So we need to help parents understand what the 4th trimester is all about. So when you're guiding these families, they may very well be thinking, well, it's normal, you know. But how are we going to get through this period? Just because my baby's behavior is normal and expected, doesn't mean that it won't be difficult to manage at times. Fortunately, there's actually a lot that we can teach parents to try to soothe their baby, decrease their crying, and make life a little easier for baby and parents. Remember that anyone can participate in these tasks. You know, so include daddy in these conversations, or lola, lolo. Identify your ally in the family, or even an older sibling. And so we need to help families understand that there is a wide range of normal infant behavior. We need to equip them with knowledge about what is normal, what falls within that range. And we need to equip parents with strategies to optimize their care, especially the safety of their baby. And we need to enable them to recognize problems so that we can institute early intervention. And lastly, we need to encourage self-care for our families, especially mothers. Okay, so this is my baby boy, 15 years ago, Santino. So we'll talk about feeding, the activities of babies. Now, feeding, crying, sleep, and lastly, briefly about growth and development. So let's talk about normal infant feeding behavior. So this is Santino's second breastfeed, already in the recovery room. He had his first right after delivery. A newborn's behavior in the first week is quite different to the later weeks. But one important principle is that normal behavior in babies indicates adequate intake of breast milk. So it's important to really understand what is normal. The baby regulates the amount of milk mommy makes because the more milk is removed from the breast, the more the breast makes milk. Supply and demand. If the baby takes what he or she needs, then the mother will make enough milk. So it's important to teach, again, if the baby is behaving normally, we can reassure the mother that she could continue to breastfeed exclusively. So what is normal behavior? Okay, I'm sure you've seen this photo in various forms. The size of a baby's stomach, it's roughly the size of their fist. So you don't really expect them to eat very much at once. Frequent small meals are normal and necessary. During the fourth trimester, baby is going to eat every 1.5 to 3 hours, usually including in the middle of the night. And very often they don't eat on a set schedule. So you may use this as a guide. Thank you to our friends in Latch. They constructed this photo. On day 1, the size of the baby's stomach is like a calamansi. That's around 5 teaspoons, a really small amount. Day 3 approaches what would be, this is a siniguelas, so around 20-25 mLs. And then at 1 week approaches the size of your kamatis, around 1 to 2 ounces. And it's only about a month the baby will really, the baby's stomach will approach the size of your egg. No, nah. And that's around 3 ounces, 3 to 4 ounces. It's very important also to teach parents early feeding cues. The babies give early feeding cues that to an inexperienced parent may be missed. They might miss this. If you miss the feeding cue, the baby may go back to sleep, especially if the baby's wrapped. It's very difficult for them to move or to raise their hands to their own mouth. So it's easier to understand the I am not hungry baby, letter E. Like us, when we're full, we're sleepy. I'm sleepy. I'm not hungry. But once they start waking up, which is around A, when they're starting sucking on their hands, moving, opening their eyes, waking up, flexing arms and legs, then they're already a little hungry. So, and we don't want parents to wait for the late cues. They're hungry, they're crying already. I'm very hungry. So they want them to respond to the early feeding cues. It's much easier to latch a slightly hungry baby rather than a very angry, hungry baby. Remember, the more the baby feeds, the more milk the mother makes. So key message, teach mothers to feed baby on demand so they can keep up their milk supply and not run into engorgement. And very often, baby eats like a monster, seems to want to eat constantly, especially for the first few days to weeks. This cluster feeding is probably secondary to a growth spurt, which happens every few weeks during the first 3 months. Infant feeding, yes, can be very tiring, can be exhausting, but it gets better. Right? Just tell parents, it will become better, a little less frequent and more predictable over the next few months after the fourth trimester. Again, the baby is the boss, but reassure parents, the baby is not the boss forever. Oops. Sorry about the animation. Yeah, okay. As healthcare providers, it's important to have consistent messaging, one of which is we advise families to target 10 to 12 breastfeeds in 24 hours. This old study, like in the 80s, shows that all babies have more than 6 feeds in 24 hours in the first week. The average around 8 to 10 feeds. So there's often what we call a feeding frenzy just before the breast milk comes in between 48 to 72 hours. So feeding frequently is the norm. And it's beneficial before the milk volume increases dramatically and really a lot of the feeding will occur at night. This feeding frequently is priming the breast for making more milk later on. So 6 to 8 weeks old, it's usually the craziest time. Many babies have another growth spurt around that time and another feeding frenzy. Again, by principle of supply and demand, this helps the mother sustain the breastfeeding long term, up to 2 years and beyond. So around the end of the fourth trimester, I usually teach mothers to try to ease into a more regular schedule of feeding of around every hour and then every hour and a half until you reach every 2 to 3 hours. So key messages. Okay, this is daddy helping with the latching. So baby is the boss, especially the first few weeks. Teach families how to recognize and respond to early feeding cues. Feeding per demand is key. Target 10 to 12 breastfeeds a day. And seek help if needed. And always remind them every visit, every checkup that this is not forever. It gets better later on. Okay, let's move on to crying. Okay, I have very few pictures of Santino crying. Here he doesn't like to have a photo. Teach parents that babies crying is really their primary way to communicate with us. And responding to your baby's cries is the beginning of them understanding that their communication will be listened to, that somebody will respond to their crying. One positive effect of crying is that it can help build your relationship with your baby. As baby continues to develop, they will begin to be able to communicate in different ways, with smiling, movement, and later on babbling. Although the amount that they cry is likely to increase, as shown in this graph, during the first couple of months, they usually peak 6 to 8 weeks. Again, that's the craziest time. It will then decrease as they are able to communicate in different ways. So again, this is really old, an old graph, 90s pattern. The crying curve. It shows the blue is the low crier, light blue average crier, green high crier. So concept here is there's again a wide variation of what's normal between individual babies and the amount of crying we have over time. Crying peaks around 5-6 weeks of age is often more frequent in the intake, then gradually reduces. Crying is really designed to make you anxious, so that you feel bad when you hear a baby crying, and that is an advantage for survival. No? So if a baby's crying, no one responds, the baby will die. No? So we are engineered. We are our brain is engineered to respond to crying with anxiety. So if you're not anxious, then something might be wrong with you. Crying and fussing is very common during the first 3 months of life. So what's difficult is that parents might have trouble figuring out what their babies are crying about. So our best advice is to ask the parent to go through the usual suspects of reasons for crying. Majority of the time, especially for the first few weeks, the baby's really hungry. But some babies also cry when their tummy's very full, or needing a diaper change, or needing to be burped. If a baby is very sleepy, or the baby is very overstimulated, some babies will cry when they're too cold, some babies will cry when they're too warm, etc. So just go through all of that one by one until you figure out the cause. And at clinic, I always ask, is there any crying that you cannot solve at home? So, and as providers, we need to, of course, be aware of other causes of persistent crying. So again, most commonly, it's really the normal newborn crying. Some babies would develop colic during this time. It's defined as crying for more than 3 hours a day, more than 3 days a week, for more than 3 weeks in an infant who isn't sick or hungry. And so colic is said to be a developmental or behavioral condition. No one really knows what causes colic, but the cure for colic is really time. So, and just reassure parents that and give them ways to try to soothe their baby, which we'll discuss later. So, some babies do have milk protein allergy or reflux. We tend to overdiagnose these conditions, but yes, do consider these. And there this list of other quite rare but important entities which might make your baby have persistent crying. Okay, let's move on. Okay, let's move on to sleep. So, of all the things we had difficulty with Tantino, it wasn't feeding, it wasn't crying, it was really sleep. So, just like everything else, the newborn sleep is not mature yet. So at first, it's normal for a newborn to sleep much of the day and be wide awake at night. So remember that they were swimming inside the womb and they were in the dark, so they don't have circadian rhythm yet. And so their brain is not attuned to when, unlike us, we're awake when the sun is out, when it's bright, and we're asleep when it's dark. The baby is baliktad. So, and circadian rhythms will be established around 6 to 8 weeks as their brain matures, and they'll switch to more sleeping at night. But at this time, baby sleep patterns are still erratic, and they spend much of their time in active or REM sleep. So putting the baby on a schedule is really not realistic during the fourth trimester. And while sleeping through the night become in a few months, it's really more the norm for the baby to be up frequently at night. So this table shows that basically babies really need a lot of sleep. And in the fourth trimester, the first 3 months, a lot of that is really during the day. And one of the proposals of Dr. Harvey Karp is really this 5S system. So supposedly to achieve no more sleepless nights. I have to say, this is not true. So it's really, the norm is really puyatan. So I usually congratulate parents before they go home from the hospital. So really expect a lot of sleepless nights because babies are really more awake at night. And it will change later on as they move out of the fourth trimester. So don't believe this no more sleepless nights. But yes, you can do some strategies to help your baby achieve soothing, to soothe your baby. So first S is swaddling. Swaddling the baby makes your baby feel more safe, secure, and soothed. Remember, baby was in a contained, warm, predictable environment in utero. So when your baby stretches an arm or a leg, your baby expects to hit something, the uterus. And being in an enclosed space will help soothe the baby. We have a slide later on how to swat. Dr. Karp suggests a side stomach position, and this is while you're holding your baby. So this is not a sleeping position. Sleeping should still be on your back, but this is a side or stomach position, holding the baby. I think what's crucial is really to hold your baby very frequently. Remember, your baby was again constantly held in the uterus, curled up, and in constant contact with something, with mommy. It takes a while for a baby to be comfortable outside the arms of a parent. If a baby cries anytime they are put down, some parents may think they have done something wrong and that their baby will never be independent. Now, this happened to us. Santino would never let us put him down. But we should rest assured that this behavior is totally normal and common. You cannot spoil your baby by holding them constantly. Carl, like this, is really doing a lot of skin to skin. So babies really have a strong sense of smell and a high need to be touched and held. So they love being held directly against your skin, listening to your heartbeat and feeling your breath. And many studies already show that this facilitates breastfeeding, infant bonding, better vital signs, etc. And this could also be the basis of baby wearing. So babies, again, are used to being squished in a cozy little fetal ball in utero, and placing your baby safely in a baby carrier like a sling or a wrap can help mimic the feeling of being back in the womb. So if you're going to do that, make sure the carrier is made for newborns and supports the baby's neck. Once a baby is secured in the carrier, check that they can breathe and that their mouth and nose are not blocked. Third S is shushing sounds. Shushing sounds. Or place in skin to skin with your baby so that they can hear your heartbeat. So, but basically, this is really also about talking to your baby. So in utero, the baby is exposed continuously to many sounds. The whooshing of blood flow, heartbeat. They can hear muffled voices. It's really more of your cadence. And at birth, newborns, their range of hearing is really most attuned. Sorry, not to music, not classical music, but they're most attuned to a woman's voice. That's why when we daddies talk to our babies, by instinct, our voice becomes higher. Hello, baby. Hello. So our voice becomes higher because we know by instinct, and we see that they respond better to mommy's voice. So in essence, talk to your baby. Talk to your baby. The other way to soothe your baby is, according to Dr. Karp, swinging. Swinging, or basically movement. Babies love to be carried and rocked. Rockabye baby. Remember, constant movement was the status quo when they were in utero. And it's really a gentle swaying from side to side. I forgot my thought. A gentle swaying from side to side, or up and down, up and down. You can also take your baby outside for a walk, and that can relax both the parent and the baby. Very, very important. Do not shake the baby. So many times I have to tell the yaya, stop the yug-yog. It's not yug-yog. It's a gentle swaying from side to side, or a gentle up and down. Do not shake the baby. Last S, the fifth S, is sucking. I had to change the picture here. The original picture is a pacifier. But sucking really is to offer the breast. So suckling is very comforting to many babies. Of course, it provides nutrition, but also comfort. It's really okay to offer the breast to soothe upset or crying baby. It's also, in our culture, it's very common for Lola to say to stop the baby from sucking on their fingers or the whole foot. So allow your baby to suckle on their fingers, hands, and feet. So when they are allowed to do this, they do this in utero, and that's really a normal behavior. And then they eventually learn na, oh, I am the one controlling this. And they realize that I am. It's their first notion of I am. Their self awareness, and it's a really natural way to self soothe, um, to do self soothing behavior. Whereas before, all their soothing is from outside. So mommy's breast, mommy's warmth. Eventually, they will learn that they can soothe themselves, and they can wait. If I'm a little hungry, I'll suck on my hand for a while and wait until the food comes. So pacifiers are not really evil, but they can lead to nipple confusion if used too early. And my partner dentists, they don't like pacifiers. They really advise to stop using pacifiers at 6 months because it can interfere with dentition. So why start? Why start a pacifier and then you have to stop it at 6 months? When you have your skin is naturally anti-infective, your plastic pacifier, once it rolls into the crib, that's dirty already. But hands they have natural, skin is a natural anti-infection. So it's better to just let them suckle on their hands, fingers, and feet. Okay, that's the 5S. So how to swaddle. Now, these things I really teach to families, especially daddy, before going home. Right? The rule of triangles, triangle, 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 and but I usually keep the chest open. So keep the chest open so that when they're in skin to skin, they can still get your direct warmth. And remember, if you're going to swaddle before breastfeeding, which can be useful, sometimes it can interfere with the movement of baby's hands. So the movement of baby's hands on the breast, scratching on the breast, also helps with the letdown. So they really can escape anyway from the swaddling. So I'm not really very strict with swaddling, especially during breastfeeding. So some key messages. Here's Cecilia, my wife, wearing Santino. We only used this. We only wore Santino because he never fit in that thing. He never fit. He was too long. So key messages. Crying is communication. Sleep patterns change. Sleepless nights are the norm. Congratulations. You decided to have a baby. Do whatever it takes to soothe baby. Do not shake the baby. Encourage self-soothing behaviors. Again, this is not forever. If you cannot solve the crying, if you cannot solve your sleep problems, then last topic, growth and development. This is a picture of Santino's first smile ever. So the fourth trimester lays the foundation for baby's continued physical growth and muscular development. If you notice here, the growth is really very rapid during the first 3 months. And of course, all of you are familiar with this. Most, if not all parents are also familiar with this. They really read about milestones. It's important to understand, though, that babies develop at their own pace. These milestones just give a general idea of the changes to expect. But we have to advise parents, don't be alarmed if the baby's development takes a slightly different course. There's a very good reason that CARP believes babies are born too soon. A newborn's nervous system and brain aren't entirely developed at birth, and it takes time for a baby to create those important sinuses that help them master skills like smiling. Fortunately, parents can encourage this brain cell connectivity by interacting with their newborn. Again, going back to holding your baby, rocking your baby, and talking to them. This fosters activity in a baby's blossoming brain. Okay, let me move faster. It's important also to emphasize that timely detection and early intervention of any potential problem in development is, of course, very important. Surveillance should be an ongoing process, parents and providers to identify risks for developmental problems. So make sure that you are aware of some developmental red flags. Now, any sign of asymmetry in movement and muscle tone at 1 month, or the baby does not have alertness to sounds or is not able to focus on an object within a few inches of the face. At 2 months, if your baby is not responding to voices, if there's no observed visual fixation and eye alignment, or if the baby is not seen trying to lift the head while lying down. You can facilitate this by doing a lot of tummy time. 4 months, by the end of the fourth trimester, if the baby is not doing these things, not cooing or smiling, not holding up his head when told to sit, not rolling front to back, not showing interest by longer staring and tracking movement of objects and voices, and not reaching, trying to hold objects. So here's Daddy doing tummy time. Key messages. Every baby is different. Follow their journey. Don't compare. But be aware of the normal pace and sequence of these milestones. Recognize red flags early. Do a lot of skin to skin. Do a lot of tummy time. Tummy time is putting the baby on prone so that they can learn how to lift their head. And expose your baby to your voice and your face. No? So you don't need those nakasabit na toys. No? So it's really, babies really respond the best to your voice, and they really respond best to the circle with eyes, nose, mouth. So, and I really put this, this is part of my first visit discussion. So no screen time, no screen time. Then any screen time is not allowed. I generally recommend screen time only at 2 years old, unless one parent or both parents, or if there's a parent who is not in the household. We have lots of parents who's working abroad, so that is allowed. If the screen time is a video call with the parent, then that I allow. But any other screen time is not allowed because that really impedes language development. I used to say no walker at 6 months old, but by that time they already got the walker during the baptism. So, but walkers are senseless because we need to follow the pace and sequence of development. So no walkers. Walkers are a danger. You fall down the stairs. They don't learn how to walk. So walkers are not advised. Lastly, the fourth trimester is not all about baby. Getting through this period means making sure parents, especially mothers, are able to practice self-care too. It's very challenging. Sometimes self-care simply means having Lola hold the baby for an hour while you nap alone, take a shower, go to the parlor. If this is their second or third baby, discuss strategies for families to deal with an addition to the family. Our role is to help families figure out what works, but it's important to make self-care a priority because caring for a newborn is a tremendous task and you can't pour from an empty cup. So here we are. This is Santina's first visit with Nina. Ninang Mian was our pediatrician and lactation consultant. So we also need help. So keep in mind, nutrition is very important for the breast, especially with regards to breastfeeding and recovery from pregnancy. Sleep is also very important, especially for the recovering mother. I usually advise families, turn off your cell phone. Turn off your cell phone. And then delegate. Many mothers want to do everything. They want to change diapers. They want to do everything. So delegate. Now, daddy is the first one to get up at night to change a diaper. Postpone inessential errands. The only errand you need to do in the fourth trimester is your baby checkup and OB checkup. Again, this is not forever, and get professional help when needed. So the underlying principle of the fourth trimester is to provide a continuum of the contained, safe, and nurturing environment of the fetus in utero, as the baby transitions gradually to a more independent existence. Providing this continuum of love and care is truly a gift and a great responsibility for every mother, every father, every family, and also for us healthcare workers. It really takes a village to raise a very, very happy baby. Thank you, everyone.
Thank you so much. Thank you very much. We are requesting for our attendees to just stay on a bit. We will extend a little bit because of the technical glitch that happened. So there is our powerful tandem for the fourth trimester care. So let's shoot na this question that is very interesting.
The
Okay, so
questions.
as a beginner open forum, we'd like to thank our sponsor, a product that's very also to me 20 years ago, also and still helping our mothers and babies now, Pigeon, for helping make this webinar possible. Sige, so let's start. Now, there are a few questions, and I think one of the most important one, I do believe, because your sessions were very, for me as a former I had 4 newborns at some time in my life. Tama, this too shall pass, right? This too shall pass, that mindset. So it was very reassuring, enlightening, calming. Sana I heard you guys nung ako'y nag-umpisa, and very practical. To the point that one of our attendees is a faculty of nursing, and I direct this question to both of you. I only know or am aware of the first to third trimester of pregnancy. As a faculty of nursing, do we need to include the term fourth try to our lecture or to our curriculum? I'll start muna with our OB, our specialist, Dr. Rosabel.
Hi. Yes, I think you have to include the fourth trimester in your curriculum because really most of the morbidities and mortalities pertaining to maternal morbidity and mortality can be seen during this period. So I think it can improve nursing care in general. When you tackle all the complications, the management during this period.
Okay, thank you. How about Dr. Resty?
We already have the first 1,000 days, the 1,000 days of we're in the pregnancy, which is 270 days, and then the first year, 365 days, another 365 days up to 2 years old. I think it's important to understand the fourth trimester in that context of the first 1,000 days. We're in many things that happen within these first 1,000 days impact adult life and long-term outcomes. So in that sense, we're already discussing the fourth trimester because we're already putting in education, government programs, healthcare programs, as well as individual care in all these periods. And I think that's really, we don't really need to, for me, we've never called it the fourth trimester, but we've recognize the need to address these very important periods in developing person from conception to 2 years old.
And I truly appreciate how holistic you've presented it, no? And since this is a critical period, really it's very enlightening that actually you've presented already sort of like the outline of a curriculum that our faculty of nursing can really glean from. So maraming salamat. Another question is regarding the care that you've highlighted. What area or which program in our barangay health centers actually, who takes care of this? Is it really a joint of the OB-pedia, or are you aware of any programs that handles the fourth trimester in the barangay setting?
If I may answer, in our healthcare setting, it's really just one healthcare worker who takes care of both the mother and the newborn, so which is ideal so that it's just one visit. So these programs are interwoven. So there's the nutrition program, and it's really a lifetime-based program. So these things are interwoven into our healthcare systems. So nutrition, so pregnancy, nutrition, childcare, they're all interwoven, and the services are ideally given in one shop. So, and that's the usually the lone barangay healthcare worker. So,
okay, thank you. How about Dr. Rose? Any?
Yeah, I think but the barangay health workers, they would usually They would usually do just 2 prenatal checkups, and oftentimes this is with the pedia, no? Also with the baby. Oftentimes this happens when they go for vaccination. So at the same time, no, nagpapa-postnatal checkup na rin. No? But DOH still recommends 4 postnatal checkups after. No, it used to be just 2, okay? But now the recommendation is really 4 for postnatal checkups, different from the pediatric checkup. No, this is really to focus on the possible complications on the maternal side.
Okay, so I also would like to invite our experts to see the Q&A portion because some of them may be answered directly already. Last question for the day is that, thanks for this wonderful presentation. I'm a UP alumni and a first-time mom to twins. Breastfeeding is too exhausting physically and mentally. Is exclusive pumping something you recommend to moms with multiple births? Is the quality of express milk still the same? And I think Dr. Rose has experience.
Personal experience. My answer will be personal experience. So I'm a mother of triplets, so I was not able to provide for all the 3. Dr. Resty helped me with during that period. Meron kaming mga breastfeeding coaches. But it was really difficult for providing for the 3 babies. So we had to shift to formula milk, unfortunately.
Yes, so okay lang to not exclusively breastfeed if hindi kaya.
I think there are special occasions when you really can't do it.
I think what's expected lang naman, Donna, is best effort. I think every parent wants what's best for the baby, whether it's single or twins or triplets. No? So every parent wants what's best for their own baby. And I think what we really just expect and what we offer to families is that we're going to do our best effort to support your choice to breastfeed. So of course there are challenges for many situations. So and to adapt to those challenges so that we can still give the optimal what's best for that moment, for that.
Definitely. Thank you very much. And so once again, thank you, Dr. Esquera Rose, Dr. Resty Bautista. So grateful for your time, expertise, your personal insight, even the stories and the photos were so wonderful, and present you with the certificates of appreciation from the UP College of Medicine 98. Thank you. Maraming salamat. And so class 98 would also like to thank those who helped make this webinar successful, the UP Manila, UP Medical Society, the Postgrad Institute of Medicine, the UP Information Service, Management Service, and our webinar sponsor, Pigeon. Thank you. We invite all our viewers to join us next webinar on COVID-19 and children. Our speaker will be, of course, our favorite Dr. Anna Ong Lim, Professor-in-Chief at Division of Infectious and Tropical Disease of the UP PGH and UP Manila. Remember, this will be held on November 29, just 2 days from now, Wednesday at 12 noon, and you can use the same links you used to register and in advance or use the QR code right here. Our class is also inviting everyone to the annual UPMAS Golf Tournament on December 11 at the Ayala Greenfield Golf and Leisure Club. This exciting golf event will include a lot of things: lunch, giveaways, a raffle, among other highlights. Interested parties or players may register by scanning the QR code or typing bit.ly/UPMASGolf in your browser. To receive your attendance certificate, kindly look at the evaluation form you can access through the QR code being flashed. We will also post this at the chat box, the URL. Make sure that the name you would like to appear in your certificate is a name that you put in the evaluation form. So next time, see you, and we will continue to unlock knowledge for primary care workers, health workers, and allied medical professionals. So God bless you, stay safe, and thank you for being with us today. Bye.